respected chairpersons, Professor Dr. Dr. Sahar, Shyam, Srinivas, and my friends, good morning you all. A warm welcome to today's scientific session. And this topic, when Sean spoke to me, it really aroused a curiosity that is widespread among clinicians, that whether these two chronic, current, modern public health curses are they linked by coincidence or correlation, or alarmingly, is there a causation between the two deadly epidemics? All over the world, across the continents, these two entities, disease entities, are seeing an alarming rise. And as per the WHO projections, the cancer burden in developing countries is going to double in the next 10 years. So whether this disease and other important public health problem, chronic health disease, chronic non-communicable disease like diabetes, whether these two are linked together. This is a question that I'm trying to address in the next 15 slides, maybe 15 minutes time. So they were whispers, and in my 2 decades of clinical practice in academic centers and as well as corporate sector, I had observed and always recorded whether the diabetes, the patient, some of the patients, especially breast cancer and colorectal cancer, whether they were diabetic at the time of diagnosis or they developed diabetes during the follow-up. So such database personally I still hold. So whether this whisper of a linkage between the two, is it just a mere correlation? Or is it really a smoking gun? Is it a causation? Then that should be a trouble. So, when you search literature, all these cancers listed here, including the breast cancer, cervical cancer, endometrial cancer, these are found to be correlated, I use the word correlated, in large epidemiological studies across the globe, from Japan to North America, from Canada to Australia. So this, is it visible? Yes. This was whisker plots of risk ratios. I think if you put down the lights and the ceiling probably, otherwise I'm really sorry. Yeah, we can okay. So this risk ratio plots have been taken from one of the mother of meta-analysis that used PRISMA guidelines, very strict evidence-based database analysis. And then you could see that a range of tumors from biliary tract to small intestine across various solid tumor types, and some of the hematological malignancies as well have been associated with diabetes. There is a gender differentiation among females in the same meta-analysis. You could see that biliary tract, liver, kidney, and then pancreas. Some of these cancers are they have more relative risk than other cancers. Endometrium and breast too. In men, you could see a different profile. You could see the kidney cancer, you could see pancreas, you could see a different cancers altogether. In male breast cancer is also has been correlated with diabetes. And just diabetes alone, we forget various things when you see a patient. We look at only one disease. there is an elephant within the room. The elephant is obesity. See, we cannot club these two diseases. Probably this is one of my thoughts that when I was reviewing this topic, I thought this is a distinct entity per se. And obesity and cancer has been linked, and we know that obesity and diabetes as well are correlated. So then in that case, the obesity, is it an interface between the cancer and diabetes? Is this a transition zone between the cancer and diabetes? Some of the thoughts that need to be explored further. So the third element here is the metabolic syndrome. Some of these patients, again, the metabolic syndrome, which encompasses having some kind of a chronic inflammatory type cytokine milieu. In some of these patients, whether diabetic or obesity alone, or there is an overlap between the three. So these two together, are being found to influence with the presentation of cancer disease in an advanced stage, more alarmingly, the outcomes, the survival outcomes, the treatment outcomes in patients, cancer patients with these features have been adversely noted in various publications. So what are the mechanisms? So since there is no clarity, there is no precision, there is no proof, all cytokines, all mediators in these three clinical entities have been blamed. So no single entity or single parameter has been yet proved to be the real mechanism, the real trigger, the real catalyst for neoplastic progression or a genesis. That has not been done. So hyperglycemia has been blamed, and I bet my instinct on chronic inflammation cytokine milieu. So there is some evidence that chronic inflammation background in these clinical entities may be one of the very important catalyst, a trigger for the neoplastic process, either genesis or propagation. So in 2017, this epidemiological basis and molecular mechanisms. So the anti-diabetic treatments, the disease per se, the clinical entities per se are probably implicated, and as well as the anti-diabetic, anti-hyperglycemic agents have also been suspects, either negatively affecting the cancer conundrum or positively affecting the clinical outcomes. Like, the metformin is anti-cancer property. It has got anti-apoptotic properties, and it has been used as some trials in metronomic chemotherapies as anti-cancer as well. And insulin, we know that is a pro-growth hormone, and it's not at all an innocent molecule, but we do not know yet that whether these things contribute to a neoplastic process at all. We don't know. These are only conjectures and complexities. So this study was published from Japan. They also noted that in this 18.5 years follow-up, that is a problem with these epidemiological studies of chronic non-communicable diseases. You require a long follow-up to identify a problem. So 18.5 years is a generation as one generation has been observed, and they found that the metabolic syndrome was a significant predictor of cancer mortality in women in the particular study from Japan. So that said, so there is a large epidemiological evidence that the diabetes is somehow related, associated with the various cancer types but we do not know how. It is not a precancer disease. But how it is related is yet to be, even today, as I speak now, is not clear. So, is it a direct relationship with various cytokines that define these syndromes to a cancer linkage? Or is it an indirect, that obesity metabolic syndrome that I mentioned earlier? Don't know. And other players, the confounding factors in epidemiological research are real elephants in the room. Look at the age. With the cancer incidence rates are a function of increasing age. And therefore, even the duration of diabetes, as the duration goes up, where the patient's life expectancy and survival goes up, how this influences? Is it a cofactor? Is it a main player? We don't know it. So the drugs used in the treatment of diabetes, sulfonylureas and insulins, are under observation. So with this kind of clinical evidence, and there was a conference in 2013, American Association of Clinical Endocrinologists. I read this statement as it is because I don't want to be biased. I don't want you to be biased. So they said, so the evidence linking diabetes is a big document. I just took a small paragraph. Evidence linking diabetes and then cancer is robust. Okay? But there is, the role of hyperglycemia in cancer development is less clear. And no other cytokine or no other parameter has also been identified as the real culprit. Right? So, there is currently insufficient evidence that anti-hyperglycemic medication may definitely be associated with an increased cancer risk. There is no evidence as of now. So, therefore it says, clinicians can continue to confidently prescribe all FDA-approved anti-hyperglycemic medications for the management of hyperglycemia according to established practice guidelines. In this document, it further says, so for instance, if there is an enhanced risk of cancer occurrence in the family, there could be hereditary or sporadic, whatever. So for such patients, an aggressive screening may be recommended. So such kind of behavioral changes may be recommended. So this kind of thoughts have been captured into this document. So, take home message, the correlation between the cancer and diabetes exists. I'm also convinced, I don't have any confusion. But causation not proven. Don't take anything out of it. The causation has not been proven yet of anything. So, how do we go forward from here? How do we establish? All of them are long players. They have a long duration of natural disease course. So, I think my thoughts on molecular epidemiology. You require a robust biomarker, very robust biomarker for pre-cancer or pre-cancer. You need a good term, a good technical term. It's not a pre-cancer. Pre-cancer is always alarming. So, before that, you need a biochemical marker wherein you can either intervene or do something about it. So you need a good molecular epidemiological studies alongside of this kind of large epidemiological studies already been done, which we have case control or cohort studies, all those been done. So with that, I think I come to end. So thank you very much for kind attention. Any comments, thoughts?
Yeah, thank you very much, Dr. Shivakumar. First of all, I should congratulate you because you have finished in time. Second thing is that, yes, the relation, the linkage between the causation or the causal association between the diabetes and cancer is still really a debatable issue.
Yes.
And you brought up very well the various mechanisms involved, like obesity and hyperglycemia, and whether drugs as a cause.
Thank you very much, sir. It's a wonderful lecture and an insight into something which I also did not know much about till a little while ago. But I have two questions before I throw it open to the floor. Does good control of diabetes, particularly type 2 diabetes, does that decrease the risk of cancer? That's the first question. And the second question is, evidence suggests that in type 2 diabetics there is an increased risk of liver, pancreas and endometrial cancer, while men somehow seem to be a little bit protected. There is some suggestion that prostatic cancer actually is less in type 2 diabetics. Just a few thoughts on that.
Yeah. The protection, you have finished? Yeah, sure. The protection, what was noted in these studies is for prostate and lung. Somehow the diabetic patients don't have this lung and prostate, that's the one. So this was first question is that so most of the studies are type 2 diabetes.
Yes. Now my question was, if somebody controls their diabetes very well, is the risk decreased? Just as a take-home message, or just the presence of diabetes itself is a risk for cancer? That's my question.
I don't mind asking.
Okay, fair comment, thank you. Any questions from the floor?
Thank you.
There's one question is there any role for screening, like, the cancer markers, the CEA, PSA, things like that in our routine health packages?
These tumor markers, the existing tumor markers, various CEA, CA125, CA90.9 and all that, they are already from established cancer, and for not established cancer, they are non-specific. That is a problem. So now with proteomics, okay, so we will be able to, I hope we'll be able to pick up something very precise and then do something. I mean, this has to be done.
Sir,
Thanks for the wonderful lecture. This is type 1 diabetics. Think of type 1 diabetics having a chronic hyperglycemia and insulin we are giving from a long duration.
Mike.
One thing regarding etiology is hyperglycemia and one is insulin, which something we discussed slides. If suppose type 1 diabetics, take the type 1 diabetics, they have a long standing hyperglycemia. Type 1 diabetics. Second thing is insulin started at the early age of life. Then any meta-analysis of type 1 diabetes with cancer, we may throw some lights into this problem. So type 1 with cancer.
Yeah, that means maybe probably is telling about
Complete
insulin deficiency. I think probably you're talking about where a condition where there is complete insulin deficiency,
Type 1 diabetics.
type 1 diabetes, and their relation with the malignancy. Yeah, in type 1 diabetes.
I didn't come across any study of that, all these studies are type 2 diabetes. There were a few studies, a limited number of type 1 diabetes, and they were, these were epidemiological studies, and there were very few numbers.
Good morning, everybody. I'm Dr. Ramarao. I'm a surgeon. This time we thought we'll involve more of postgraduates and specialty students. We would encourage all of you to ask a few questions, mainly exam-related questions. All of the consultants here are quite senior. They're in both academic practice and private practice. We want to ask anything about, Dr. SambaSivaiah is very clear about this topic. I don't think there are any further questions. But even in a scenario like this, if there is a case of pancreatic cancer, we would definitely be asked about the relation between diabetes and prostate cancer. Something similar. Where your exam say, any small dogs in a daily practice, a word note, and anything you can ask anybody. And this time, we would like to have more involvement from postgraduates. Any of you can ask any question. If there are no questions, we'll go to the next topic.
Right. Thank you very much.